Okay, thank you very much, and thank you for the invitation. So Mike has already introduced some concepts that are going to be relevant for my talk, so thank you for that, and thank you for a really brilliant talk. I just wanted to warn you that unfortunately nobody gave me any money to give this talk, but still I have some images of commercial systems with label and the slide from Hyperfine. So we've seen already we've seen this yesterday in Beatrice's talk. We've seen some of it this morning. There are some challenges in bringing MRI to low field. And the main one for sure is the issue of signal to noise ratio. We have already seen that the signal to noise is proportional to field strength. In this graph, it looks almost linearly proportional, but as Mike said, we may disagree on the exact power, but we all agree on the fact that if you go to higher field, you get more signal to noise. And signal to noise in MRI is like money, because you can spend it to buy what you want, if you want higher resolution, if you want shorter scan time. So when we move to low field, we have to deal with the lower SNR, which invariably results in lower resolution, longer scan time, or both. If you're interested in the brain like I am, often you observe changes in contrast that might work against you, like, for example, a reduction in the white matter to gray matter contrast. And not very much has been done in terms of looking at using contrast agents at low field, but it's very likely that they probably show lower effects than at high field. So the question is, why would we want to go to lower field MRI? Well, there are also many advantages. We have also already seen them in the previous talk, the main one being the reduced cost, not only in buying the equipment, but also in maintaining and running the equipment, less requirement on the siting. We have improved accessibility and portability. We have lower power consumption, less susceptibility to certain artifacts. We have a much better safety profiles, which basically makes MRI accessible to patients that would not be safe to be scanned at higher field. We have lower power deposition that is not only good for safety, but also enables the use of pulse sequences that a high field would basically be unfeasible in vivo. And we have these changes in contrast, which sometimes work against us, sometimes work in favor, and can be exploited for new applications. And so all these advantages have always been there, but as we have all witnessed in the sort of past 25 years, the trend has always been the opposite. We move to higher and higher field strength, and suddenly we are witnessing a renaissance of low field MRI, and that really has been brought about by improvements in hardware, and particularly, I would say, in software with the advent of artificial intelligence that have made low-field MRI feasible and effective, at least for some specific applications. And I would recommend looking at this review paper by Jürgen Hennig, which really gives a very nice historical perspective on how MRI really was born at low field and how this field has sort of evolved in the past few years. So we've seen already what we mean by high and low field. I just wanted to stress the fact that we have these two sort of broad categories at low field. We have the sort of low to mid field, where we're still working with superconducting magnets. So we still have the need for large rooms, for shielded rooms, but we also have a much better performance in terms of what is possible with gradient strengths, what, the B0 field homogeneity, and so on. While when we move to the sort of category of the portable scanners, obviously these are the lighter and a lot more flexible in terms of design, like we've seen in the previous talk. But because they are designed to be portable, therefore the main requirement is that they have no RF cage, they are permanent magnets, they don't have cooling, which means that we can't really go to very strong gradients. So all of these hardware constraints, while they make the scanners cheaper, maybe easier to build, at the same time have an impact on the quality of the data that we obtain and what is really feasible with the systems. So this needs to be kept in mind. That is not just the field strength that changes, but essentially everything changes when we move to these portable systems. And as we've seen already, there are some commercial systems that live in this area. I've just put these two here, the Hyperfine Swoop, which is a head-only scanner, and the Promaxo, which is primarily for prostate imaging, while in the range of the superconducting low field, we also have some commercial systems, and the Siemens Magneton Freemax is the same that Mike has already shown to you earlier. So the companies are getting really interested in this space, and that's also what helped to prompt this field. So what are the emerging applications? There are many. I've listed here the main one. We have, with this portable system, we can really start to think about bedside imaging. Interventional MRI, obviously, has already been mentioned by Mike, has a real chance to blossom with these new systems. We have enhanced accessibility in resource-limited settings. These type of scanners might be better suited for populations such as pediatric and neonatal. And we also have, I've listed cardiac MRI there because it's one of the applications where the changes in contrast might actually be beneficial. And the musculoskeletal imaging as well, because with the possibility of developing these extremity systems that are really portable and can effectively even replace X-rays for some applications. So I don't have the time to go through all of this today, so I'm just going to be focusing on two of those, which is the bedside imaging and enhanced accessibility in resource-limited settings. So why bedside imaging? Well, we know that standard commercial MRI equipment is bulky, requires a large amount of space, and requires dedicated rooms with electromagnetic shielding. So this effectively means that no other medical equipment can be brought inside the MRI room, or very few. And so if you have patients that are critically ill and need to be connected to other machines, they essentially cannot go into the MRI room. Also, transportation sometimes can be a risk. So effectively, MRI is not accessible for this type of patients. So what is the solution? Well, if you can't bring the patient to the MRI, perhaps you can bring the MRI to the patient. And this is where this point of care MRI really aims to go. And this is the one slide from Hyperfine that shows the main differences between the traditional MRI, where aside from the cost, you also have a significant difference in size and weight. And the Hyperfine, which is shown on the right-hand side, and the concept at the corner is that basically you need the same power to operate the scanner that you need to operate your coffee machine. So, and this is, okay, I'm sorry. This is an example of how the scanner is actually portable. This is John Evans, our MRI lab manager, that is wheeling this scanner across the corridors of Kubrick. And we have our patient that some of you may recognize being scanned here. And we are literally doing this in the corridor. So the scanner is actually controlled through a tablet with protocols that are pre-designed. The operator doesn't even need to really position the scan, because there is only a head coil and the position is kind of fixed. So all kind of simple and really fairly portable. The scanner has its own little motor that moves it, and the person who moves it just needs to sort of steer it. So examples in which this can be important is, for example, stroke. If patients are in intensive care unit, we know that diagnosis of stroke and distinction between stroke and cerebral hemorrhage is really important, because it has significant implications for treatment. So And so time is really key, and often these patients in intensive care might need to be connected to medical equipment. So here's where some of these systems might be useful. Here, there have been a few papers that have looked into the effectiveness of these systems for the diagnosis of stroke and distinction from cerebral hemorrhage. This is one of these papers that actually showed that the performance was fairly good. The raters correctly detected the cerebral hemorrhage in 45 out of 56 cases, and blood negative cases in 85 out of 88. And this was compared against the conventional standard of care, which was either CT or MRI high field. So in this particular paper, they only looked at FLAIR and T2-weighted scans on the portable system, but obviously we know that diffusion is the standard for diagnosing stroke. And obviously diffusion is very challenging, diffusion MRI, to do at low field because it's a SNR-starved technique, and we're already starting with low SNR. But regardless, diffusion weighted imaging was already presented, for example, by Hyperfine, and just to mention a commercial system. There's been quite a lot of other examples throughout the years. This was presented at ISMRM in 2022. And as you can see, the quality of the image is not great. The images are very noisy. The maximum achievable B-value is 900 seconds to millimeter square. But what they were able to show in this work is that these images are actually clinically relevant, because on the ADC map, you can clearly distinguish the stroke in blue and the hemorrhage in green there. So there's really promise for this type of application. And when we say portable MRI, we don't just mean portable across the corridors of your hospital. This is a paper by Sean Dioni, who actually put one of these scanners on the back of a Ford Transit, and still after loading the scanner on the transit, the truck was still below its gross weight rating, and the magnetic field outside of the van was everywhere below 2 Gauss. And you can see that here in a schematic that shows the magnetic field. Oops, sorry, need to go back. So the scanner was operated using a portable battery supply, and essentially he could drive around North America and go to people's homes and get them into the truck and scan them. And just another example of clinical applications. This is in multiple sclerosis, where essentially, the key here is having enough resolution to be able to detect lesions for diagnostic purposes. And in this paper, the authors showed that in general, the performance at 64 millitesla was comparable to that at 3T, with the exception of very small lesions that were beyond the resolution obtainable at this field strength. So again, in this case, it's not an emergency, but because these patients often need to have recurring scans, especially if they are on disease-modifying treatment that might have side effects such as PML. So often these patients have to travel long distance to have their regular MRI checks. And something like this, if it was based at their GP practice, obviously would make their life a lot easier. So moving on to accessible MRI, here the need is quite different. The motivation is that in many low to middle income countries, both MRI and CT are unavailable, and yet there is a high burden of disease with neurological complications. So there are places in West Africa where there is, at best, 1 MRI unit for every 5 million people. That's quite different to what we're used to in the Western world. And the problem is not just the cost of buying the machines, because that could be overcome with donations and so on. But the problem is that once you have an MRI machine, you need to ensure service, maintenance, power to operate it, and so on. And so this is a fairly common view in some of these countries that medical equipment gets donated, but then at the first time that it breaks down, even if it's something that would be really easy to fix in Barcelona or in London, they actually do not have access to engineers, they do not have access to parts, and so the medical equipment simply gets thrown away. So these low-cost systems that are also a lot simpler from an engineering point of view to fix could be a solution. And this is an interesting paper by Karen Chikuti, who essentially describes their experience in Malawi in receiving and implementing one of the scanners in the hospital. And it really gives a very practical but also eye-opening view for people who are not used to this kind of environment to see what might be the actual challenges in setting up something like this, but also very positive because they actually were successful in setting this up and the scanner is now operating in Malawi. So I've become interested in low field as a part of the Unity project, which is the ultra low field neuroimaging of the young, which is funded by Bill and Melinda Gates Foundation. And this project essentially brings together several sites in North America and Europe to develop imaging on these low field systems that are also deployed to lower to middle income countries for applications in the first 1,000 days of life of children to look at what interventions might change their life outcome. And as part of this consortium, there's been quite a lot of interesting work that has come out, and some of it has focused on simple measurements such as white and gray matter volume. And here what I'm showing you is how, because you can't really achieve high resolution, you can't do MP-range on these systems. So the trick that was used here to get volumetry was to acquire images along 3 planes, so having high in-plane resolution, and then combining the 3 images to get high isotropic resolution. And they were able to show that you get very accurate estimates of white and gray matter when compared to the 3T equivalent. And here you can see examples of these volumes in adults, infants, and neonates. So I mentioned earlier that ML and AI have really made it possible to this renaissance of low field. And here is another example of how this can be done. Here you can see a standard T1 weighted image obtained at 64 millitesla, not very impressive. T1 really doesn't give a great contrast at these field strengths, but T2 works much better. Here you can see a T2 weighted scan. And in this work by Lisa Ronan, what she tried to do was to, starting from this image, learning the contrast that you will get at high field in a T1 weighted volume, and then apply this retrospectively. So this approach, which is called image quality transfer, allows you to produce a synthetic T1 weighted image. And what is interesting is that if you do the same thing with a T2 scan obtained at 70, you get a T1 image that is almost undistinguishable from the one that comes from the hyperfine. So this is where we really start to leverage on these techniques to improve what we can do at these field strengths. And we have worked towards implementing DTI. These were the very first DTI images that we obtained at 64 millitesla. These were relatively low p-value, 600, and obviously there are some artifacts. So lots of problems to address, but at the same time, you can see that some of the typical feature of white matter can be seen on these images. So there's information there. And we worked on improving this DTI in collaboration also with scientists at Hyperfine. And after 2 years of working on it, this year at ISMRM, James was able to show that we can actually do constrained spherical deconvolution from images obtained at 64 millitesla, and you can start to even estimate crossing fibers and stuff like that. And using this, you can get tractograms that start to look really quite pretty. So you may ask, is this really relevant? And why do we need to take any of these to countries where they don't even have access to basic healthcare? And obviously, these are two different needs. But, oh, I forgot to say, the scan time is a bit long, but we're working on making it a little bit shorter. So you might think this is not relevant, but yeah, I mean, there is the need for both. There is the need to respond to the healthcare emergency, but there's also the need to really support the development of neuroscience in Africa, because they are understudied population. There is so much that we could learn, and also we want to support the building of a community there, because that's what is needed in order for this field to flourish, for the manufacturers to actually go there and support the equipment there. So there's really the need for both things to grow together. So just to leave you, what is the future of low field MRI? I mean, I don't think that low field will replace high field, but I think that there is really good momentum for the two to work together in different ways. We need to find the right applications for low field, but also combine the two systems. And also, what will be the role of low field in high income settings? I mean, I can foresee a future where you go to your GP with a headache and they might be able to give you a head scan there and then you can go home feeling relieved that is nothing bad. Or maybe it just serves as a sort of a triage for the people who actually need to have a high field scan, reducing therefore the waiting list that at the moment, even in very in very rich countries, can still be really long in some geographical areas. So just want to finish by thanking all the people that I work with, and thank you for your attention.